to make a difference. Let's make today count as we expand our knowledge and skills. We wish you all a very good morning and take great pleasure in welcoming you all to the third annual Endowment Oration at Chengalpattu Medical College in association with the Chemco Alumni Trust on the topic Life Before Birth, A Beautiful Journey.
The Chemco Alumni Trust was formed on 10th November 2011. Under the banner of the trust, it recognizes the students who outshine academically by way of awarding them medals for all the subjects starting from anatomy to community medicine. In addition to that, our Chemco Alumni Trust is annually extending its support by sponsoring various college events including Tamil Mandram, sports events and college magazine.
With a vision to appreciate and inspire the budding minds of this great institution, the Chemco Alumni Trust initiated this novel academic program in collaboration with the Tamil Nadu Dr. MGR Medical University, namely the Chemco Alumni Trust Endowment Oration from the year 2022. We now take great pride in welcoming you all to the third annual Chemco Alumni Trust Endowment Oration on the 7th of January 2025.
We are honored to have several renowned guests who have contributed greatly to this event. We would like to invite our esteemed dignitaries to the stage for inauguration ceremony.
We welcome our Dean, Dr. S. Shivashankar Sir, to please come to the dais. Professor Dr. S. Suresh Sir, Dr. S. Manoharan Sir, Dr. K.P. Pichumani Sir, Dr. A. Paneer Selvan Sir, our VP, Dr. A. Anita Ma'am, our Medical Superintendent, Dr. Jyoti Kumar Sir, our DMS, Dr. Padmanabhan Sir.
Immense pleasure to invite our dignitaries to the dais. We welcome our Dean, Dr. Shivashankar Sir, our Vice Principal, Dr. Anita Ma'am, Dr. S. Suresh Sir, Dr. Manoharan Sir, Dr. K.P. Pichumani Sir, Dr. A. Paneerselvam Sir, our Medical Superintendent, Dr. Jyoti Kumar Sir, to the dais. We also invite President of Alumni Association, Dr. Kulothonga Soran Sir, and Vice President of Alumni Association, Dr. Mohan Kumar Sir, to the dais.
Prayer, in its essence, is a solemn and reflective act, a moment to seek guidance, strength, and wisdom. As we gather here today, let us take a brief pause to reflect, pray, and invoke the clarity needed to inspire and guide our efforts in this noble field of medicine. We now request all of you to please stand up for the Tamil Thai Varthu. நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் வதனமென திகழ் பரத கண்டமைதல் தெக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகவுமே
Thank you all. To experience the togetherness as a proud Chemco, we now have the audio visual of Chemco theme song.
Thank you for that wonderful audio visual. We kindly request the dignitaries to take their seats on the dais, please. We also invite Dr. Anil sir and Dr. Shekhar sir to also join on the dais, please.
Light in various traditions symbolizes purity, wisdom, and divine presence. Presence of light can transform the space, making it conducive for spiritual and ceremonial activities and enhancing the sense of solemnity and joy. We now request the dignitaries on stage to light the Kuttuvilakku.
Thank you, everyone. In observation of prayer and condolence for the Chemcos who have passed the previous year, we request all of you to please stand up and close your eyes for a minute. Thank you all. Please be seated.
We now invite Dr. Panneerselvam sir, President of the Chemco Alumni Trust, Chengalpattu Medical College, onto the dais to deliver the welcome address.
Sorry to just between. I request all the alumni here who are seated here, including the present people here, to come on the stage and please take a photo along with us when the lights are still. You are all lighted up this college, and this college is flourishing because of all. Please come, sir. Please come, sir. Please come, sir. All of you, please come.
Thank you all. We now invite Dr. Selvam Sir, President, Chemco Alumni Trust, onto the dais to deliver the welcome address. Please, sir.
Good morning to all of you. I feel proud and happy to stand in front of you as Chemco Alumni Trust President. And again, I feel proud and happy to have Dr. Shivashankar as Dean. He only told me, but I have not forgotten. While I was doing my PG in 87, he was also in the same ward, Penland ward, under Dr. V. Murugesan. So I was student of Dr. Murugesan during third year, final year. I did PG under him, MD at Stanley. Then at the time of retirement, I worked under him as assistant also. So that is the long story. So we feel very happy and proud, sir, as a dean we are having here. And again, we wholeheartedly welcome on behalf of Alumni Trust and our Alumni Association for this function, sir, this endowment, third endowment oration. And another senior most person from our batch is Dr. Ilango. Dr. Ilangovan sir is from the day one of inception of this Alumni Association, that is 97, almost more than 25 years. So he is continuously getting involved. Similarly, our today's orator, Dr. Suresh, also, he is continuously getting involved. Of course, the founder of the Alumni Trust is our Dr. Annal. He is the man who initiated the game and met all the people all over Chennai and all over even Tamil Nadu and organized. Of course, our Dr. Segar is consolidated everything and he made many members, all the members at present are because of sir only. Not only he made them as member and he consolidated the money and put it in the fixed deposit as safe custody, so nobody can touch. So fixed deposit, through that interest only, we are happily conducting for more than 5-6 years. We formed the trust in 2011. So from 2011 onwards, we are giving medal exam, prize exam, and helping the students and conducting such CMEs and oration for the past 3 years. So all because of our Dr. Segar sir and all the senior people who have come here. For example, Dr. Sambat, Dr. Keshamurthy, Dr. Govindaraj. Dr. Govindaraj, myself worked in Vilupuram. He used to work in the Aswani hospital. I used to go there as a consultant. All other senior people, all my office bearers of trust as well as association, and the senior faculty of Chengalpattu Medical College and Hospital, office superintendent, RMO, and our vice principal, Dr. Anita, is Chemco alumni only. So she and all the assistant professors and students. We, on behalf of trust, I wholeheartedly welcome you for this very interesting topic. Today's topic you might have seen. So life before birth and a beautiful journey. So not ordinary journey. So life after birth only turmoil. Life before birth, you are simply sitting in the uterus and happily enjoying the uterine environment. But after birth only, the turmoil starts. So life before birth. So after seeing the topic by Dr. Suresh, I was enjoying the topic, and we are also enjoying the topic. We are going to enjoy the lecture also. Once again, I wholeheartedly welcome all of you for this third endowment oration. Thank you.
Thank you, sir, for your kind words.
It is now time to felicitate the dignitaries who have spared their valuable time to grace the event. We request Dr. Kulothunga Choran sir, 1984 batch, President Alumni Association, to felicitate Dr. Selvam sir. Thank you, sir.
We now call upon Dr. S. Sudhakar, sir, 1997 batch, Secretary of the Alumni Association, to felicitate Dr. S. Manoharan, sir.
Thank you, sir. We now request Professor Dr. S. Ilangovan, sir, 1965 batch, former President Alumni Association, to felicitate our Dean, Professor Dr. Shivashankar, sir.
Thank you, sir. Now we call upon Dr. A. Panneerselvam, sir, 1975 batch, President of Alumni Association, to felicitate Professor Dr. S. Suresh, sir.
Thank you, sir. We now call upon Dr. Mohan Kumar, sir, 1995 batch, Vice President Alumni Association, to felicitate Dr. K. Pichumani, sir.
Thank you, sir. Now we call upon Dr. Sampath, sir, 1967 batch, to felicitate our Medical Superintendent, Dr. Jyoti Kumar, sir.
We call upon Dr. Shekhar, sir, 1970 batch, to felicitate Dr. John Vasigaran, sir.
He is the senior most physician of Chengalpattu. He is also a teacher also.
Thank you, sir. Now we call upon Dr. Shekhar, sir, 1970 batch, to felicitate our Vice Principal, Dr. Anita, ma'am.
Thank you, sir. We now call upon Dr. Anil, sir, 1979 batch, to felicitate our DMS, Dr. Padmanabhan, sir. We thank all the dignitaries who have graced the event today. Thank you all. We now invite Dr. S. Manoharan, sir, Secretary, Chemco Alumni Trust, onto the dais to deliver the Secretary report.
Respected dignitaries on the dais and off the dais, I am very much proud to be in front of you to state that I was the youngest old student to attend the first meeting in 1989, when the World Students Association was started by the then Dean Dr. Shanmugh Sundar sir, with the initiatives of Dr. Annal sir, Dr. Selvaganapathy sir, and O.V. Jayakumar sir. So still I cherish the memories as a youngest world student. Recently on 14/7/2024, the trust board members elections were held at Magendra World City and new office bearers were elected and 28 board members constituted. On 11th August, new office bearers assumed office. On 29/10/2024, a Zoom meeting was held to discuss about the further progress regarding the next venue for the next alumni meet, then increasing the members, alumni patron and life members, like that. Then on 29/11, I met our present dean at Alinjaratna Memorial Cancer Hospital, Kanjipuram, which is attached to our Chengalpattu Medical College since 1980 for teaching purposes, and felicitated him. On 19 December, I felicitated our 1988 Chemco, Dr. Hilarina Joshita Nalini, who was promoted and joined as Joint Director of Health Services, Kanjipuram. I request our faculties, Chemco faculties, here to add more patrons, specifically our Vice Principal, Professor Anita, and Professor Dr. Arasu, who are more closely involved with the students, to add more alumni, so that the final year students or pre-final year students becomes life members by paying 1,500 rupees. Now the procedure is very simplified. Online you can pay in a single sitting. You can direct them in a classroom and make them pay. Similarly, CRRIs, when they get their first stipend, after 3 or 4 months, they will be getting a bulk amount. So at that time, RSU can motivate them to become patrons by paying 5,000 rupees. As Shagar sir told, 5,000 is not a big amount now. So please motivate them, because only 1,500 members are now. Among them, 700 are patrons, 800 are life members. So we have to make the life members into patrons and others as life members and patrons. If only we generate fund, we can do more activities. Please bear it in mind, and more we will discuss it in the afternoon board meeting. Thank you for the opportunity. Thank you.
Thank you, sir. We extend our gratitude and invite Professor Dr. S. Ilangovan, sir, 1965, the very first batch of Chengalpattu Medical College, who has donated medical textbooks to the college libraries and general books to the hostel libraries.
These are the list of books that I have presented to the yes, sir. And our Chemco Alumni has released in August, sir. This is my journey since from 1965 till this day, that is on the day of this release. It's all about my alma mater, my professors, the doctors who have graduated from Chengalpattu Medical College, and the students of the Chengalpattu Medical College, and the future students of Chengalpattu Medical College. I have dedicated this book, sir. I am proud to present this book, sir.
Sir, these are, especially this book, sir, it's very priceless contribution, sir. And I was born in 1965, sir. So you are.
Nice coincidence. Because
So it is.
sir, you suits very well with the topic what we are, our Professor Suresh is going to deliver.
Yes. So my lifetime is your experience, sir. Thank you very much, sir. And we are so grateful to you, sir. Thank you, sir. Thanks.
Thank you, sir, for your generous contribution. We now call upon Dr. Shiva Prakash, sir, 1969 batch. 1968 batch will be handing over books authored by him to the dignitaries on the dais.
I am Dr. Sivaprakasam from Chidambaram. I am in developmental pediatrics. I have created a booklet which is useful for all the parents to monitor development by themselves because autism is increasing now. It is 1 in 39 or something like that. So we need to reduce the incidence and also we need to identify them early. So this contains immunization and developmental card which parents themselves can monitor development by themselves. So it is very easy for everybody to use it. And we have conducted a workshop. It is called Developmental Assessment Made Easy Workshop all over India. And it is a module which I am giving to our dean for taking up. And it contains all practical things which we need to understand. Within 6 hours, it's a work-oriented workshop which we are conducting everywhere. So all of you just have the booklet, Tamil booklet, and I will send it by WhatsApp. You can forward to all the parents who have children with 0 to 5 years. And Suresh is my mentor, and he guided me so many things. And because of him only, I've been interested in improving further. This is the first thing which I did. After that, I did this because of the stimulation which is given by Dr. Suresh. He is from my college. We conducted an exhibition during our period, 68 to 70 or something like that. And he is taking up lot of interest for creating that exhibition. Congratulations, sir. Thank you, sir.
Thank you, sir, for your contributions. Now I invite our pillar of strength and support, our guide and mentor, our respected Dean, Dr. G. Shivashankar, sir, to give the presidential address.
Good morning, everyone. Good morning, everyone. Ellarkum vanakkam. Respected dignitaries, teachers and teachers of teachers, and professors of professors, all the professors, respected Dr. Suresh sir, Dr. Panneerselvam sir, Dr. Pichimani sir, and Dr. Annal sir, and Dr. Manohar sir, and all the dignitaries on the dais, respected VP madam and MS sir, and all the professors and assistant professors, associate professors of our college. Good morning. It's a big honor and privilege for me to be here in front of all of you, sir. You are all great teachers, and you have guided so many people, and I think your students and your students must all be in very big positions. And I won't take much time. Dr. Suresh, I used to go once or twice to his ultrasound center when I was MBBS student. So we didn't know much about ultrasound. So we used to just go there and see what he was doing. And when I was doing my MCH urology, sir, I came once for the anomaly scans. And Dr. Panneerselvam, sir, when I was a house surgeon in Dr. V. Murugesan sir unit, he was doing PG. And all of you know about VM sir, what a great subject he was. Similarly, all of you know about Panneerselvam sir. What a great subject and how successful sir is. His brother also is very close to me. Yes, sir. And all the other dignitaries and all the other professors on the dais, thank you very much for coming here and then doing this program. And this program, actually, when I saw this topic, life before birth, a beautiful journey. Yes, it is such a beautiful journey, but also a dangerous journey. So this only shows us how great God is. God is always great. And I remember, without being born without any disability or deformity is such a great boon for humanity. Sir. Yes, sir. And I know that Dr. Suresh was one of the first persons who initiated the anomaly scan. And it is such a useful thing. And I think, sir, you also initiated some interventions. Yes, I remember it, sir. So, sir, we are proud and honored to have you here to give this endowment lecture, sir. Thank you very much, sir, for coming. Thank you, one and all. Thank you very much.
Thank you very much, sir. We request all the dignitaries on the dais to present a memento as a token of honor to our respected Dean, Dr. G. Shivashankar, sir.
Thank you all.
Now, on to the most awaited session of the day, the Endowment Oration on the topic, Life Before Birth, A Beautiful Journey. We welcome Professor Dr. S. Suresh, sir. We invite Dr. Panni Selvam, sir, to read the citation about the presenter.
The third Chemco Alumni Trust Endowment Oration, citation, Professor Seshadri Suresh, MBBS, FRCOG, Honorary, DSc Honorary, and pioneer in diagnostic ultrasound and fetal medicine. Professor S. Suresh, a graduate of Chengalpattu Medical College, 1970 batch, began his career in general surgery at Voluntary Health Service, Adayar, before receiving specialized training in ultrasound under Dr. Hemant L. Shah in Mumbai in 1982. He established Mediscan system, Chennai's first ultrasound center, laying the foundation for the development of diagnostic ultrasound and fetal medicine in India, for entire India. Dr. Suresh has played a pivotal role in establishing fetal medicine as a recognized specialty in India. Mediscan has been instrumental in offering advanced diagnostic, therapeutic procedure, and fetoscopic surgery in 87. Additionally, he initiated dedicated departments of perinatal pathology, genetics, dysmorphology at Mediscan, solidifying its position as a premier center for comprehensive fetal care. Driven by social responsibility, Dr. Suresh has ensured access to fetal health care through free and subsidized services in collaboration with the Tamil Nadu government. He and his team have trained 350 doctors under the NRHM project in basic obstetrics and ultrasound to improve rural ultrasound accessibility. In 1983, he and his wife, Dr. Indra, established a training center at Mediscan, which has since trained more than 5,500 doctors worldwide, not only in India, worldwide. He also contributed to training as a member of Basic Training Task Force of the International Society of Ultrasound in Obstetrics and Gynecology. In 1991, Professor Suresh founded the Fetal Care Research Foundation, an NGO dedicated to prevention, support, and treatment of birth defects. He pioneered India's birth defect registry, a groundbreaking initiative aimed at improving the maternal and child health outcomes. His initiative's contributions include internationally adopted imaging software, and a web portal for standardizing ultrasound reporting and education. Professor Suresh was awarded the Honorary Fellowship of Royal College of Obstetrician and Gynecologist, London in 2010, recognizing his outstanding contribution to the field. Professor Suresh serves as Honorary Secretary and CEO of VHS, where he joined in the surgery department. He joined there as Honorary Secretary as well as Chief Executive Officer of VHS Adayar, transforming it into a modern institution of affordable health care. He is a professor of practice at IIT Madras, mentoring students in healthcare technology and founding member of Healthcare Technology Innovation Center. Additionally, he holds visiting professor roles of Srihar, Chennai, as well as PhD Institution of Higher Education, Coimbatore, contributing to perinatology, research and education. He is also trustee of Cancer Institute of Adayar, the Vision Research Foundation and Child Trust Medical Research Foundation, Chennai. A prolific contributor, he has delivered over 900 lectures, conducted 200 workshops, published 110 scientific articles, and received 30 prestigious awards. He continues to advance medical education, research, and standardization of ultrasound process across India. Beyond this professional achievement, Professor Suresh, an avid nature photographer, he started his, while I was first year student, he was house surgeon. He used to always wander the camera only. So he is continuing that. Beyond his professional achievement, Professor Suresh is avid nature photographer, amateur radio operator, and Rotarian. His visionary leadership and outstanding contribution to healthcare and education have earned him recognition as a pioneer in the fetal medicine. He has served as President, Managing Trustee of Chemco Alumni Trust from 2017 to 2024, which is growing in strength year by year. On the Chemco Alumni Trust and Chengalpattu Medical College take immense pride in honoring and selecting Professor Seshadri Suresh to deliver the third Chemco Alumni Trust Endowment Oration on Tuesday, 7th of January 2025 at his alma mater. The members of the committee feel this occasion is a celebration of his exceptional contribution to the field of medicine. Thank you.
We request all the dignitaries on the dais to present the citation to our dear Dr. Suresh sir. Thank you, sir. Now we request Dr. Ilangovan sir from 1965 batch to present a medal of honor to our beloved speaker, Dr. Suresh sir.
Get training at his Mediscan Ultrasound Scanning Center. There is a waiting list of 1 year for the doctors. But whenever Chemco approaches him, he immediately trains them. Chemco, spirit.
For the recognition of our medical college, we belong to the first batch and we came out and we finished our course 71. To get the recognition, all the photographs have been taken by Suresh and submitted to the Indian Medical Council during the time of inspection. So that was enormous work done by our Professor Suresh. I just want to read on this.
Thank you all. We now call upon Professor Dr. S. Suresh sir to deliver the endowment oration. Over to you, sir.
First of all, let me wish you all a very happy new year from Mediscan family. And I'm truly overwhelmed to stand here before you today. And distinguished Professor Shiva-Shankar sir, Dean, and other my fellow colleagues from the Alumni Trust Association, and my mentor and teacher, Professor John Vasigaran. I still remember I learned how to examine a patient from him. And he was generous enough to allow me into his clinic, in his private clinic, to stand by to see how he handles patients. Now that grounding has stood me till today, because one of the important things is the focus is the patient, and patient always. Nothing else matters. And some of the lessons we learned here as a student in this college is something which we can never forget. And it has really formed a foundation to be one of the finest things about this college is it makes you for life be a good human being. Because that, wherever you go, you know your limits, you know who you are, and you operate within that ambit of what you can do. So thank you very much for not only being, I'm grateful to God for making me part of this institution, and also choosing me as an orator for this distinguished oration. Before me, we've had two very distinguished orators, and me being the third one, I feel truly honored, and thank you for that. So today, I'm going to talk about life before birth. Life before birth, I consider it as a marvel of creation. It's absolutely a fantastic journey, and it is a place where you start identifying, once you start understanding how the fetus grows, what it does inside, and how it prepares itself for a journey outside, you start wondering what it is. And I'll tell you some concepts which I have understood, and you'll realize at the end of the day, we need to be grateful ever the fact that we are here, what we are in this world. So the question is, where does life begin? We all started off as probably a single cell, two cells which came. Then fertilization happened miraculously. And when we grow, there was a time when pregnancy was identified clinically. Then came identification by biochemical markers. And much later came the ability to visualize the pregnancy as we go through. And the point of visualization, I should say, is a completely transformation point of our understanding of what this fetus is all about. And then we found that there were a huge amount of surprises at birth. I mean, there are many people who have delivered twin pregnancies or triplet pregnancies. They never knew they had twins. And at that time, the only thing you need to do if the abdomen looked very big, an X-ray will be taken to find out whether a single baby or twin baby. An X-ray will be taken to know whether the head is down or the baby was a breech presentation. Today we have transcended all that, and there are several pathways this baby takes to reach a final destination. The final destination, as far as the family is concerned, is they want a healthy baby. And what is it we can do in between is what we talk about today. Now, in the 70s, we had ultrasound. When I trained in ultrasound, the images looked somewhat like this. It was a static image, and it was a black images on a white background, and the machine was almost occupying half of the room, and it used to take, we had to just do scans like static scans, and then to know whether baby was alive, we had to listen with the peanut stethoscope. But then in the year 1975, the world was taken by storm and what we call as real-time ultrasound came into being. And I had the fortune of, when I was training, the first real-time ultrasound machine came in India and it was there for a demonstration purpose. So I had a little bit of hands-on on that. The transformation point was seen at that time. And it was absolutely remarkable. And what has happened subsequently is this level of sophistication of ultrasound machine has gone such remarkable heights that the applications of ultrasound went far and wide. It was not only obstetrics, but every field of medicine has an application in ultrasound. And naturally, the equipment had to fine-tune itself with that, different kinds of probes, different kind of... Today we talk about POCUS. POCUS is point of care ultrasound. And if a person comes into the emergency room, an ultrasound is needed. If a patient in the ICU, an ultrasound is needed. To know whether to give more fluid or less fluid, the ultrasound is needed. And that is the remarkable aspect of ultrasound as a modality by itself. But in the beginning, there was a lot of skepticism. When I first started the machine, I went to several senior obstetricians and said, I've started an ultrasound center. I'd be happy to scan your patients. And the message I got was, my hands are better than any ultrasound machine, because clinical examination played a huge role at that time. And I still respect that, because I think clinical examination is better than ultrasound is what they used to say. And truly, because when a senior gynecologist referred a patient to me saying, there is a lemon-sized mass in the pelvis. If you go and scan, there will be a mass in the pelvis and it will be lemon-sized. That was the remarkable thing. And if there was a disagreement between the clinical finding and the ultrasound, I used to get very worried and I will not report that case at all. I'll go back and tell you have found it, I'm not able to find it, but probably we've had cases like that. And finally found out that she was true and ultrasound could not pick it up. That was a remarkable clinical acumen which our teachers and people had. And today, but we have to say, we have to transcend. When technology improves, we also have to go along with it. And then, but we have to use the power of the technology in a very, very judicious way. And that's what I'm going to take you through today. The aspect of screening for Down syndrome is a great example, where at that point there was no belief in screening for Down syndrome, till one day that obstetrician delivered a baby with Down syndrome and the parents asked, could this not have been detected earlier? And immediately from that, the faith in Down syndrome screening came. So Professor Eavesville, again one of my teachers in fetal medicine, said we have moved from an era of obstetric ultrasound to an era of ultrasonographic obstetrics. There is no obstetrics today without ultrasound. Every single patient needs to get an ultrasound, and that is part of what we call a standard of care. And we have to do it at specific points and timelines. So in the late 70s and early 80s, most of the referrals were in third trimester. And I would be surprised, they'll send a patient saying, I'm planning to do a cesarean section tomorrow. Please do an ultrasound to find out whether there are any abnormalities. Now, what are we going to do by finding abnormalities at the stage? She will not have a cesarean, she will have a normal delivery. This is all, that was all the way ultrasound was used. And then gestational age. People said if the biparietal diameter is 9.3 centimeters, she is ready to be delivered. But we know today all that is far from the truth. And we've understood the variability, the biological variability of the baby's growth in utero, and we have special charts for us which does that. Then came the fetal environment. So the baby is growing in an environment, and the index of well-being is always the baby's movements. If the baby was moving well, then the baby was well oxygenated. And that holds good even today. And with ultrasound, we can do a little bit extra, and we use a technology called Doppler to find out whether the baby's oxygen status is good. And then when in the assessment of the growth process, we found that the world is a very large world, different countries. So one person in the US created a chart which said if the baby is 20 weeks, the size of the baby should be so much, the size of the abdomen should be so much, the size of the head should be so much. And very soon we found different countries the baby was growing in different growth paths. And so we needed to establish growth standards for each population, which is what is being used today. Now, there was also a very big debate in the 80s, and I had participated in a very vehement debate with an obstetrician who strongly believed that a routine ultrasound should not be done in a low-risk patient. If a person is a primee, she is 25 years old, there's no family history of anything, she doesn't require an ultrasound. And that was a debate. At that time, I argued that ultrasound is absolutely required, and every patient must have ultrasound, at least one ultrasound in the pregnancy at 20 weeks. We have moved far away from that again, because today, as I will show you, that the time of ultrasound has gone down from 20 weeks to 12 weeks. And what all we can achieve in 12 weeks, I'll show you. So at that time, the studies also said routine ultrasound is not going to be helpful, but that's changed completely today. So the concept of screening in the unselected population started coming, and suddenly all the organizations in the world started producing guidelines. And they said there's a concept of level 1, level 2, level 3 ultrasound, whether you're doing basic scans or very advanced scans. And this was mainly done to mitigate, because once ultrasound was capable of doing something, the expectations from the family also went up, and in case something was missed, they went to the court, and that became a problem. So, so then the big shift came, and suddenly Professor Michael Harrison from the US, he said, you are no more going to call it as a fetal ultrasound, because the fetus is now a patient in its own right. So the transformation of a fetus as a patient came in the 80s. It was called as the unborn patient. And this was a very remarkable change. Suddenly people started focusing on the fetus to identify what all it does. Does it, why is it moving? Why is it moving in a particular way? And why is it growing in this particular direction? And structurally how the baby is. All this was done because the focus was on the unborn patient. And Professor Michael Harrison did another remarkable thing. In as late as 1983-84, he found a baby with an abnormality, a diaphragmatic hernia, and also obstructive uropathy. He decided, he was a pediatric surgeon, he opened the uterus during pregnancy, pulled the baby out, repaired the condition, put it back inside, and allowed the pregnancy to continue, and the baby was delivered later. Imagine in 1983, this was called as fetal surgery. And today, it has come resurgent back, and I'll show you some of the things about what happens today. So if you look at the evolution from 1950s to 60s to 70s, where with the power to invade the uterus, that we could safely go and put a needle inside the uterus and take out some tissue and send it for analysis, which is called chorion villus sampling or amniocentesis or umbilical blood sampling was done, and in the 80s that's open fetal surgery. And in the 90s, genetics started improving a lot, because once you remove the fluid, what are we going to test it for? So the transformation from basic genetics, just from karyotyping to microarray, to now we are having next generation sequencing, which is happening. And then came one step further in the 90s, where that they developed instruments, like they said, okay, we have laparoscopy where you can do keyhole surgery for the adult. Why can't we reduce the size of that instrument and try to do a keyhole surgery for the fetus? And today it has become, again, one of the standard methods of treatment of some of the conditions, which we call as fetoscopy. So the need in all this, the need for a systematic scan came. What do you mean by that was, so the fetus had so many, the human body has so many parts. With ultrasound, how many of these parts you are going to see? And when are you going to call a fetus as normal? All these questions were raised, and finally we said, well, let's go for a systematic method. And we at Mediscan developed this the 7-step approach, and 3 planes in each part of the body, 3 anatomical planes are for the body, and then we give cutoffs of normal limits which are there, which is being used today. So this is called standardization. So that when number of people start doing ultrasound, everyone has to do it exactly in the same way, so that you will get the results can be interpretable. Now then the tectonic shift. I call it the tectonic shift because from bigger the better to smaller the better. Bigger the better, 18 to 20 week scan was the standard at that time. But then Professor Kypros Nikolaidis from the Fetal Medicine Foundation, he came and said, no, wrong, because all scans must be done between 11 to 14 weeks. Now why 11 to 14 weeks? Because when you look at abnormalities, embryogenesis is completed by 10 weeks. So if there was any major anomaly, it should present by 11 weeks or 12 weeks, you should be able to see it. And ultrasound technology has also improved, and the whole thing changed around. And then they said there are top 4 conditions that can require early prediction during pregnancy. One is preeclampsia, second is fetal growth restriction, third is anomalies and aneuploidy, and also preterm birth. So early diagnosis paved way for prevention. Early diagnosis, there was informed choices to the patient, and treatment. So while finding out anomalies at 24, 25 weeks or so, we brought down the time of detection to around 12 weeks or so. Right. So then, the 11 to 14 week scan became the cornerstone or the first decision-making milestone in pregnancy, and it has stood the test of time. And today, every patient must have scan at 11 to 14 weeks, because you can do dating, you can do number and chorionicity. We can find out 90% of chromosomal abnormalities, 70% of anomalies, and 80% we can predict this woman who is going to get preeclampsia in pregnancy, but it has not solved the problem of whether she will go in for preterm labor or no at this point. So this is what is called as the inversion of pyramid of prenatal care, because originally in prenatal care, women used to go for checkup later in pregnancy. Then slowly that then became 32 weeks, then 24 weeks, then 16 weeks. So very few women went for checkup at 16 weeks. All of them went only in the second trimester and so forth. Today, all women go for treatment at 12 weeks. You start the process at 12 weeks, and then you reduce the number of patients who actually require detailed intensive care later in pregnancy. So you can put them on the pathway. You are a low-risk pregnancy. Going on this pathway, your outcomes are likely to be better. You can deliver in a place, even in a place where there is basic facility available, or you need to go to a place where a higher-end facility is available. So you can triage the patients using this, and that's a remarkable achievement, I should say. Now, in the first trimester, our own journey, we started systematic first trimester scans in 2006 and 7. And 2009 to 10, there was increasing acceptance among the obstetricians, so more patients started being referred for first trimester scan. And in 2010 and 11, we established what is called as a first trimester unit, which means in that scan room, only first trimester scans will be done. So there were 2 people there who are doing morning to evening only first trimester scans. So they became better and better and better in identifying the fetus. And we established another, just as we did for the second trimester scan, we established a rule called the rule of 2 approach. And then we started looking at the fetal heart, because at one point of time, the heart was beating or no was the only thing we would look at. But then we started looking at the details of the heart. We could get the 4-chamber view, we could get the outflow tracts, we could get the 3-vessel trachea view, and we could identify cardiac anomalies. And today, nearly 60% of cardiac anomalies are diagnosed at 12 weeks, and we can make very informed choices. Right. So when you look at screening for aneuploidy, that is basically screening for Down syndrome. In the 1970s, it was only maternal age. In 1980s, we had what is called the triple screening and the quadruple test, which had a 60 to 70% detection rate. And in the 1990s, we did a combination of ultrasound, 11 to 12 weeks ultrasound, and free beta HCG and PAPE called as a combined test. And in this, the biggest marker we found was increased fluid behind the neck of the baby, which we call as nuchal translucency, and that was a strong pointer for the presence of Down syndrome. And so a process established across the world. They said there should be a process for screening. So there were a woman comes into pregnancy. In pregnancy, there is a priori risk for that woman. Then you modify that risk using ultrasound biomarkers, and then you have a cutoff and say she's screen positive or screen negative. If you screen positive, then you do further testing to identify babies having the problem or no. But then technology does not stop. Remarkable change. What happened was that one very bright doctor in Hong Kong, he saw that when he was taking mother's blood for testing, and when they were looking at it, they found fetal DNA in the mother circulation. And suddenly, I had access to the fetal DNA by not going into the fetus and putting a needle into the fetus. By just taking the mother's blood, I could know I could find out whether the baby was boy or girl from the mother's blood. I could find out whether the baby was Rh positive or Rh negative from the mother's blood. And it could also tell us whether the baby had a high chance of Down syndrome. And the detection rate for Down syndrome, because of this called non-invasive prenatal screening, has gone up to greater than 99%, which means the number of amniocentesis and invasive procedures has gone down significantly. Right. So a good process of screening evolved, and with the cell-free, it's called as the cell-free DNA test, and this has come to stay. And now what they are doing is to find out genetic disorders in the fetal DNA in the mother's blood. Still, a lot of validation has to happen, but we are reaching there, and very soon I think we will reach there. Now, let's look at a word by prediction of preeclampsia. What we used to do is, by looking at for prediction of preeclampsia, is to do a second trimester uterine artery Doppler. By doing a Doppler of the uterine artery, by finding out the resistance, we could say this woman is at high risk for preeclampsia or no. But then it was too late, because what is the treatment you are going to give? The only treatment that was available to be given was aspirin to the pregnant woman. But then giving it at the second trimester was of no use. So they shifted the whole thing to the first trimester, and by doing a combination of uterine artery Doppler, maternal blood pressure, and biomarkers, you could get an 89% prediction of preterm preeclampsia, early preeclampsia, and 62% prediction of preterm preeclampsia. This was a significant change, and when you identify a person at high risk for preeclampsia, you give them aspirin 150 milligrams per day taken at night. It reduced it modified and reduced the risk. It did not take away the risk, but it modified the risk, and the number of women who had severe preeclampsia came down significantly. This was a milestone. And then they said, instead of your uterine artery Doppler, can we look at something else? And remarkably, we found that you just need to keep the probe in the mother's eye, and you find out the ophthalmic artery, and you get the waveforms of the ophthalmic artery, and it predicts preeclampsia as well. So, which means, again, technological improvements here. Right. So, then comes detection of abnormalities. In the 1980s, overall detection for fetal anomalies was only 30%, and today overall detection rate is more than 70%. And there's various identification, structural markers, and in 2010, we could actually go and look at the inside the brain of the baby, and we found that there is a lucency called the intracranial lucency, which is nothing but the fourth ventricle of the baby. You could identify the fourth ventricle and then say whether the baby has spina bifida or no. So simple screening, and it was very, very effective. So as I told you, we need to examine the baby. So now our whole process is that we have started looking at the fetus as an individual, right? And when you look at an individual, we think in our mind, this is a newborn baby which is going to a neonatologist. How will the neonatologist examine the baby? Can I do the same thing in utero? Because it's only an extension. This life is, the newborn life is the extension of the in utero life. So a systematic method of examination starting from head to toe is started, and that's what we call as the rule of two. Then we start becoming very greedy. We become greedy because we identify something. So can we identify something more? And we found the number of cardiac anomalies were being missed at 12 weeks. Said, let's evolve a technology to a technique to do this. And this, by switching on color Doppler and looking at two inflow tracks and just the outflows from the heart, suddenly the pickup rate of cardiac anomalies shot up like anything. So all this is because we are now, when you move the probe, yes, now I want to examine the cardiovascular system. Now I want to examine the central nervous system. So we go system by system. It's not we are looking at the head, we are looking at the abdomen. We are going by system, genitourinary system. Look at the kidney, look at whether the urine is passing, whether the bladder is filling and emptying, whether the baby is opening and closing its eyes. Suddenly, functional aspects of the baby started, we start looking at it. And then came the technology of three-dimensional ultrasound. So the moment three dimensions came, we all thought, okay, all our problems are solved, that we can now visualize the baby not in 2D, but actually 3D. So here you can see the early 9 weeks 3D patient here, and a baby with a proboscis, with a holoprosencephaly, and a cleft lip and palate, which can be there. Now, remarkable thing was, when I used to diagnose cleft lip and palate, many patients were skeptical. They used to go and get a second opinion, and they were, but when you show them the 3D picture and show there is a cleft lip there, immediately they are able to understand. And when this patient goes to a pediatric surgeon who's going to operate on the cleft lip, he's able to understand the 3D image much better, and he counsels the patient in a much better way. So technological improvements in that, and you can see how the spine and the ribs are also brought out extremely well in this. Then, of course, again, we are even more greedy. Then said, can we do something more? So we go beyond the realm of ultrasound, and fetal MRI came as a concept that we need. So it is not done routinely for all patients, but in patients with cranial disorders, for example, migrational disorders of the brain, you can do actually MR tractography to find out the tracts which are there in the brain and counsel the patient methods. Then adjunct to ultrasound. Then we have done the structural abnormality part. Now we look at fetal growth. And when you look at fetal growth, you can see all these graphs are what we call as nomograms. These are population-specific nomograms, and for each of them. So when we plot, when a baby comes to us, we measure, like a tailor who's taking measurements for the baby, we take measurements of the head, we measure the abdomen, measurements of the femur, and then we plot it on the graph to see whether it is growing according to a particular trajectory. And very interestingly, there are 3 rules of fetal growth. Every fetus has its own growth rate. Every fetus maintains its growth rate. Supposing a baby wants to grow on the 10th centile, it will continue to grow on the 10th centile, and younger fetuses grow faster than older fetuses. Very important, because I'm going to show you the analogy between a newborn and the fetus, where fetus is very young, that is early pregnancy. You scan them every week, there's going to be some change. When you go later, the change will not be as evident as that. So then by doing the growth, we find out whether the baby is not appropriately grown. So there is a baby which is not appropriately grown. We call it as fetal growth restriction. Now, why? Because the placenta is not functioning well, nutrition is not transferred well. So this, once it's growth restriction, now the mother is worried, everybody is worried, what's going to happen next? Now, the natural history, if you see, when there's a constant nutrition and oxygen lack in the baby tries to fight itself. The baby is a great survivor. Okay, it doesn't give up very easily. So once the baby is growth restricted, it finds the nutrition is not enough. It will suddenly conserve its energy because all its fat stores will slowly be depleted, and it will redistribute all the blood from the intestines, from the adrenal gland, from the lungs to the brain, because at any cost the brain must survive. That's the natural instinct of the baby that happens. And this is something which we can find out with Doppler. So we find out with Doppler whether the baby is redistributing, whether the baby is hypoxic, and then we can optimize the timing of delivery, and you maximize that, because if you deliver too preterm, the baby will die because of preterm complication. If you wait too late, the baby may have an intrauterine demise. So by judiciously using a combination of ultrasound and Doppler, we can optimize the timing of delivery so that the outcomes are better. And what we need to achieve is intact survival. And for this, the role of Doppler can be very useful. We look at the umbilical artery Doppler, we look at the middle cerebral artery Doppler, and the ductus venosus Doppler. And again, one milestone in the development is the advent of Doppler, which we could identify. Now, let's go for a little bit of more advances in technology, fetal medicine, genetics. So from assisted reproductive technology, where we know that IVF has become such an important thing, and these test tube babies which have been talked about, and several centers have come up. From assisted reproductive technology, we now have possibility of life grown in a lab. Here is a lab which they have constructed. They can go up to 30,000 babies in a year, where the entire baby is grown in a created outside uterine environment. Of course, this is still in the experimental stage, not that can't do it tomorrow, but I think that's where the technology is moving. Because for women who have removed that uterus is surgically removed, women we cannot have the baby of their own. Now they go for surrogacy. Instead of surrogacy, this could be another option which could be there. So why is this? Then what else do we understand here? The fetus inherits the genes from the parents and also has its own unique set of genes. So genetic alterations can occur, and this is something which again a huge transformation has happened, as I'll show you. And the word we use today is epigenetics. Now that means that you have the father, you have the mother's genes, both of them there. So sometimes the child resembles the father, sometimes resembles the mother. Some of the characteristics also it genetically. So you have a Nobel laureate, and we expect the son to be very bright. And because they will say somebody is very, very bright, who are your parents? So probably you inherited gene from your father or your mother. They say that. But this epigenetics can change the whole scenario. And what do you mean by that? We have an environment. You have a genetics. We have an environment in which that individual is growing. And the effect of that environment on the genetics is change the phenotype or change the structure of the baby. So for example, this when there are environmental exposures, for example, stress, diet, lifestyle, they induce epigenetic changes which actually turns genes on or off. So it is under your control to live a healthy life. If you keep abusing the body with various different kinds of things, it can slowly over a period of time switch off some genes and switch on some genes that are not necessary. So this epigenetics plays a major role in our thing. So, and also how does it happen? It transmits in generations. So for example, this is a generation. So a woman who has, let's say a woman smokes during pregnancy. Now this smoking, it induces epigenetic changes in 3 generations at once. The one in her, then the baby in which the baby she's carrying, and when that baby comes out and reproduces, the effect of that smoking is seen in the last one. And this is called as fetal origins of adult disease. So when there is severe growth restriction in utero and the baby has a very severe growth restriction, these babies will have a higher chance of hypertension, diabetes, very early onset hypertension, diabetes later on. We call this as fetal origins of adult disease. So that means life is a continuum. It's not like you have finished your in utero life and then you're starting a new life after birth. It's not like that. Whatever things have happened in utero, the effect of that is felt over a period of time. So maternal conditions, emotions, habits influence the fetus after birth also. So what happens when there are genetic disorders? Genetic disorders result from spelling mistake in the gene sequence. Very simple spelling mistakes. For example, the word enough. This is our normal spelling. The word ENUF also sounds enough, but it's not the correct spelling, right? That's wrong. But there's also another spelling called fetal, and fetal, both are right. Even though it's a different spelling, both are right, because one in the US and one in the UK, they spell it differently. So where do we lie here? So there are some innocuous spelling changes. For example, gray and gray, it's not nothing, no effect on the baby. Whereas read and read, if it's R-E-E-D, that's wrong. Okay, so that baby is going to have a problem. So the 4 words like A, T, C, and G combination is what is giving you the genetic disorder, and these spellings have to be understood. Like it's like some hieroglyphics which is there. So that's why today we have large libraries of genetic disorders where these spellings are rare, and when a baby has a genetic test, you can refer to that, and from the library you'll say, okay, this corresponds to this deletion, this altered spelling mistake corresponds to this disease. So now I come to the crux of the whole thing, which is the life of a baby from conception to delivery is a miniature version of life from birth to old age. Now I'm going to prove this to you, and I'll come back at the end to show you how exactly we compare in utero life and the ex utero life. So during the journey, the fetus acquires skills just as we do after birth, right? The sense of touch and pain, hearing, emotions. Fetus inside has emotions, and I will show you how we see that. So through this journey, the maternal womb is an optimal, stimulating, interactive environment for the human development. Activity never ceases, and the fetus is never isolated. You think the baby is growing alone inside that womb? It's not the truth. Because you have on both sides the iliac arteries and the uterine arteries, which blood is flowing like a river, and this causes turbulence, and the baby is able to listen to this turbulence. Okay, different, the highs, the lows, everything. The baby is also able to hear noises from outside, and it reacts to noises from outside, right? So touch is the first sense, is the cornerstone of human experience and communication beginning in the womb. So touch sensation has already started long ago, right? So then motor movements. The fetus in motion can see very early as 8 to 9 weeks. The baby is very active. You have bursts of activity followed by rest. So the baby is moving very actively. Just watch it for a few seconds, suddenly it will become quiet. It will become quiet and remain quiet for a long time. What does the newborn do? The newborn will be very active when it is awake, then suddenly it will go to sleep. Sleep for a long time. Suddenly it will awake. The moment it is awake, it starts moving. So the same cycle is seen in the in utero period, the periods of wakefulness and periods of sleep which are there. Then fetal activity patterns. Now there are specific activity patterns that happen. Flexion of the head, extension of the head, flexion of the thorax and lumbar region, then pelvic rotation as early as 8 to 9 weeks. And then the swallowing starts about 10 to 10 and a half weeks. Swallowing is a very important thing for the baby because it participates in the amniotic fluid regulation cycle. The baby passes urine, and the urine is the amniotic fluid, and the baby swallows the amniotic fluid. So there has to be a balance between the quantity of urine produced and the amount of fluid swallowed. And while swallowing, because the baby is inside the amniotic fluid, the fluid enters the lungs. And we realize that we say, oh, fluid should not enter the lungs. But in utero lungs is already inside the swimming pool, and it goes inside the lungs, and it's essential for it to go inside the lungs because that keeps the alveoli open and the development of the lung takes place because the amniotic fluid goes inside the lung. In a baby with oligohydramnios where there's no liquor, then those babies, when they're born, they will have lung hypoplasia. They won't be able to breathe. So when in case of bilateral renal agenesis, for example, where the baby is not producing urine, the baby does not die of renal failure, but the baby dies of inability, hypoxia due to inability for the lung hypoplasia. And then you can see the breathing movement. The breathing movements of the baby are usually abdominothoracic. Abdominothoracic, you can see the diaphragm move up and down. And this we look for in the second and third trimester, and it's a very good sign of cerebral oxygenation. If a baby is breathing very well, then we know baby is well oxygenated and we reassure. The fetus is also sensitive to the environment. When a mother laughs or coughs, her fetus moves within seconds. So when I'm doing the scan and I want to get a particular position of the baby, I just tell the mother, can you cough? When she coughs, suddenly the baby will jump and move. So the mother, it knows that some disturbance is taking place and it responds to that very nicely. Then the sense of taste and smell. So the fetus swallows and breathes the amniotic fluid. This helps in the development of lungs and GI tracts. I wanted to watch this mouth, and you can see the tongue inside. It's opening and then swallowing the fluid. Actually, the tongue movements are there in the process of swallowing. Okay? Then how do we know the baby has got a taste? So this is a baby with a goiter. So, it's a hypothyroidism. So we treat the baby with L-thyroxine. Okay? So we give the injection of L-thyroxine. See what happens when I'm giving the injection, that the needle, as soon as I give the injection, the baby will open its mouth and then swallow the fluid. Right? When you keep it near the mouth, immediately it will swallow. And the people have tried giving lipiodol. Lipiodol is very bitter. When you put it, the baby will not open the mouth. This has been proved, scientifically proved. So, and this thyroxine, so I tasted the thyroxine, actually it was quite sweet. So this shows that baby has got taste and it does very well. And newborns, very interestingly, are drawn to the odor of breast milk. Because when they are born, they don't know anything. But automatically they are able to latch onto the breast and they feed it. They are all drawn to the odor of breast milk, although they have no previous experience with it. It may come from cues they have learnt in prenatal life. This is the picture. Then look at fetal breathing. You can switch on the color Doppler and you can see the fluid going through the nose, coming out of the nose. The red is coming out and the blue is going out. So constantly fluid is going in and out. And the baby, after the baby is tired, it also starts yawning. And this movement is very different from the swallowing movement which you have seen before. Nicely opens the mouth and then slowly puts it back. Yawning is a very specific activity which the baby does. So whatever we are doing outside, the newborn baby keeps yawning all the time. So, right. Then fetal urination. Very important again. There's an autonomic control of the bladder. Once the bladder fills up at a particular point, automatically the baby the urine is emptied. There is decreased production during sleep. You can see the urine coming out there. And there is decreased production during sleep and increased production while the baby is awake. Like what we do, isn't it? While sleeping, the production is lesser, while awake the production is more. Now, next is listening and hearing. Now, here is something very, very interesting to know. So, I think this thing is not coming. So the audio is not coming. Yes, sir. Audio? So I wanted to listen to this music. So this listening and hearing starts by 24 weeks. Some musical sounds can cause changes in the metabolism. This music is called Braham's Lullaby. It's a very famous music. When you play it 6 times a day for 5 minutes in a premature baby nursery, faster weight gain than voice sounds played on the same schedule. Right? This has been proved, and now newborn nurseries have music. I'm sure pediatricians here will agree with me. Newborn nurseries have music and they do that. So this can be given in the in utero period. But then see what happens. Look at this. Now if you're going to give this kind of a sound, the baby will have a startle reaction. You go suddenly shout in front of the baby will jump, and you can see it on ultrasound. So that shows that the baby is responding to the sounds. Now, a mother came and asked me, you're saying this, the baby from, so can you find out whether the baby can hear or no? So can we find out deafness, congenital deafness in utero? They're very important because there was a family history of deafness. Unfortunately, we cannot do this at this point of time, but that's a thought. that we should find out ways and means of whether the evoked potentials can be obtained from the baby ear to find out this. But that's work in progress. Then we look at auditory function and speech perception. Very, very important, because the neonatal behavior is related to fetal experience, right? Recognition of maternal and paternal voice after birth. Remarkably, if a newborn child is there and the parents, the father has participated a lot during the pregnancy, which is there constantly, they are talking to each other. When the baby is there in the room, when the father comes and gives a voice, the baby will immediately turn and recognize the father's voice. It will always recognize the mother's voice better than, if a stranger comes, it will not respond very easily. If the father comes, it will respond. So this is also been proved, right? So who do you think this is? Lydian. So Lydian Nadaswaram, son of Varshan Satish, a Tamil music director. He started playing piano at the age of 2. And who is this? Veena Gayatri, daughter of Veena Vidushi Kamala. Right? So, constant music in the house while they were in the womb. That, when the child is born, already all the musical sounds, everything is gone. They are able to come, perform as well as do. You can see this in many, many places where a musician's family, you can see children coming better. In a dancer's family, you can see the children becoming dancers, children or grandchildren becoming dancers, because they are exposed to it in in utero environment. And this we have to be aware. Why I am saying this is because our grandmothers used to say, when a pregnant woman should not be exposed to any calamities, any other things, give her the best of things, and all the relatives will come and see her, everybody will come and bring sweets and do all that. It was a celebration. Pregnancy was a celebration. Celebration because they wanted the baby growing inside to have the best of environment coming to it. Today, pregnancy has become an anxiety state. They have converted into an anxiety state. That's because of medical technology. There is no doubt about it. Absolutely because of medical technology. So, then what about vision? What about vision? The prenates with their eyelids still fused seem to be using some aspect of vision. 30 weeks, the baby has the capacity to react to light. And here you can see the eyelids which are there. You can see opening and closing of eyelids. And transabdominal, if you illuminate with a torch, you can see the fetal heart rate increasing. Heart rate will increase if you shine a torch inside to that. So that means through the abdomen, the torch goes inside, and not in very obese women, of course, in where the penetration is good. This has also been shown to be so that shows that vision is there. Now let's come to pain perception, because one of the biggest questions that are asked is, you're doing invasive procedures on the baby. Are you giving pain to the baby? Are you doing anything to alleviate that pain? So here, this is a 12-week fetus. I'm taking the needle and trying to touch. You can see the moment I touch the leg, the baby is moving away from that. Right? So that you can start moving away. So pain perception is felt at this stage. And here is the second trimester where I'm putting a needle. The baby was quiet, but the moment I put the needle, it started struggling and started moving a lot. And you can see the jerky movements which are there because the baby is feeling that pain. But this needs to be proved, right? So the proof of this comes from this evidence that the fetus responds to pain by excessive movements, and with needling, a fetus shows rise in beta endorphin levels up to 590% and cortisol levels to 183%. These are all proved by tests. So this means that fetus is something which is responding to everything. All these systems are not activated after birth. All the systems are activated well before birth. Now, what about fetal reaction to mothers? Okay, when the mother drinks 1 ounce of vodka and a glass of diet ginger ale, breathing movements stop within 3 to 30 minutes. That's why they say don't drink during pregnancy. Okay, it has a profound effect on the fetus. Maternal anxiety and stress profoundly influence the child behavior after birth. And I keep telling this to all my patients, because the moment you say there's a small choroid plexus cyst, then anxiety starts, they think of the worst thing that can happen. It's up to the medical profession to tell them they should only get concerned when we say this is a matter of concern, and they should accept that one. So here you can see the impact of maternal emotional state during pregnancy on fetal heart rate variability. The fetal autonomic nervous system is believed to be negatively affected by maternal adverse emotional stress. Prenatal levels of depression or anxiety, for example, are linked to a higher concentration of cortisol, which in turn is associated with fetal motor activity, infant stress reactivity, and nervous system development. ADHD is also being related to maternal anxiety states which are there. So again, our responsibility is gone. Very few pregnant women seek help for mental health. Even if they are stressed, it's only the obstetrician who handles without. So we need actually a mental health specialist for the sake of the baby. For her it may be fine, but for the sake of the baby and the outcome, we need to do it. And so then does the baby sleep? And how do we know a baby is sleeping? Right? So when the baby is sleeping, I wanted to look at this, that's the lens. But you can see the movement of the lens, very rapid movements. This is called as rapid eye movements. REM sleep is what we also go through, and that's what the baby also goes through inside. Right? And then dreaming. Yes, the baby dreams, because study on premature babies have revealed intense dreaming activity occupying 100% of sleep time, and at 30 weeks, and gradually diminishing to around 50% by term. So when the baby is full term, the dreaming goes down, right? And then we also dream, but dream of different things. Do that, right? Now fetal emotions, certainly, yes. You can see the baby crying, the baby yawning, and the baby also smiling. So different emotions, different reactions. We don't know at which point of time why they are yawning, but one thing we have seen, the startle reflex is very, very clear. The moment you suddenly give a jerk or something, the baby will do that, and at that time when you capture a 4-dimensional ultrasound, you can see the fear in the face of the baby. So we need to be careful. Right? So then here you can see pregnancy with lots of findings. There's pleural effusion, there's microgranthia, strawberry head. It's highly likely to be chromosomal abnormality. We do a karyotype, it is absolutely normal. Structurally, baby is abnormal, but it looks like abnormality, but no. So next is you identify a fetal abnormality. Now the whole life of the fetus changes. What is the direction that is going to take? If there's an abnormality, the assessment is going to be whether this is compatible with life or not compatible with life. If it's compatible with life, what is going to be the morbidity? Short-term morbidity and long-term morbidity. How are we going to answer all these questions? By doing additional testing, like we do counseling, we do microarray, next generation sequencing. Then we come to a final diagnosis and then make a decision making whether to do expectant management, treatment, or sometimes the patient wants to terminate the pregnancy. So that brings us to the last part, which is prenatal invasive diagnostic and therapeutic tests. The advent of molecular testing has changed the scenario in a very significant way, and there's also more access to genetic services now, and also perinatal pathology forms a very important role. So we call this as the MADAM concept. It is multidisciplinary antenatal diagnosis and management. Now the fetus is no more in the hands of the sonologist. The fetus now is in the hands of every subspecialist that is possible. You have the high-risk obstetrician, you have the geneticist who comes and plays a role, you have the fetal medicine specialist who plays a role, there's an anesthetist in case you need to do a surgery, the anesthetist is important, and there's a perinatal pathologist who need to give information. There's a neonatologist. Neonatologists are playing a very important role in the antenatal care of women. Plus also subspecialists. It could be a pediatric orthopedic surgeon if there's a spinal deformity. It could be a pediatric cardiac surgeon to tell them about how this cardiac surgery will be done. Extremely important. So from a single person, obstetrician, scanning, then go back to obstetrician, deliver. This was the cycle. Now from obstetrician to scanning, if it is normal, go back to the obstetrician. If it is abnormal, go through a variety of specialists before you can go back and say make a decision. So that big route has done, and this is what we call as fetal medicine. So when we talk of prenatal diagnostic procedures, We can take tissue from the fetus, like from the chorion villus, we can take samples, or from we do it around 12 to 14 weeks, and after 15 weeks we do an amniotic fluid sample, or a little later we can actually get a fetal blood sample. Supposing I'm suspecting fetal anemia, then I can't do an amniocentesis. I have to go and do a fetal blood sampling to find out the fetal hemoglobin. And these procedures have to be found to be fairly safe. We have done in our own center more than 35,000 procedures, and very safe, we can say we can do very, very safely. Now, we used to do fetal skin biopsy. We have done 27 cases of skin biopsy, where you can see a very special biopsy. For example, the first baby has got an oculocutaneous albinism, or epidermolysis bullosa, or congenital ichthyosis. Then we go and do a skin biopsy. But this has completely given up, because today we can identify all that by molecular diagnosis. I just need to take a little bit of chorion blood sampling and send it for genetic testing. I will get the answer. I don't need to go and pinch the baby, pull out the skin. A very difficult procedure to do. So from karyotyping, we went on to microarray, and we went on to next generation sequencing, because the yield, when there are anomalies, microarray will give you 6% additional yield apart from karyotyping. And of course, the more you test, okay, the higher the problems are likely to get into. When you do a very high level test like next generation sequencing, you will get results pathogenic, likely pathogenic, non-pathogenic, variation of unknown significance. So when they give you likely pathogenic, you don't know what to tell the patient. When you say variation of unknown significance, yes, there is a variation, but we don't know what this variation is going to do to the baby. So the mother has got an abnormal result, but we can't save anything more. That's a very difficult situation to handle. But this is, we need to do. So the question comes is there a normal? So there are many babies with variation of unknown significance born and absolutely normal. Absolutely normal. So the question comes is, what is meant by a normal human genome? So this Nobel laureate who came to Chennai gave a lecture on this human genome project, and somebody asked him, can you define what's a normal human genome? And he said, there is nothing known as a normal human genome. There is nothing known as a normal human genome. That is, our normalcy, what we think as normal, is because if you are able to talk to me, if you are able to go to school, if you are able to eat well and do whatever you run around and do whatever I am doing, you are normal, right? But the abnormality is a very, very different thing. So the role of perinatal pathology. So this patient came to us with recurrent non-immune eye drops. Again, eye drops. We didn't know what to do. So finally we said, give the baby for autopsy. And in the autopsy we found Gaucher cells which are there. So now we know that this patient has got a Gaucher disease, and we could do molecular diagnosis very early in pregnancy next time and give them to do that. So in our center, we have done 17,000 fetal autopsies till now, and this huge number of patients, we have been able to give them a good direction of how to approach the next pregnancy, which becomes a final diagnosis. And that, of course, led to the birth defect registry. Right. Then fetal therapy. So we have now, we have the power to identify a problem. And the mother is asking me, can you correct the problem? Can you correct the problem while the baby is still inside? They don't want to wait till the baby is born. Or some problems have to be corrected inside, because if we don't correct inside, the baby is going to die immediately after birth. So, for example, anemia, hydrothorax, the lower urine tract obstruction, chorioangiomas, and also twins, complication of twins like twin-twin transfusion, selective growth restriction, and also tachyarrhythmias, critical aortic stenosis. All these potentially are treatable. But there are big problems in decision making. Who is to decide what type of procedure to do, and what are the other challenges, patient logistics, cost of coping with failure, family anger, lot of things are there. But nevertheless, we have crossed many of these boundaries, and we are able to provide. One of the fallouts of huge number of IVF centers is production of higher order gestation. We have actually seen 8 babies growing, octuplets. Okay, octuplets is the largest number we have seen, septuplets, quadruplets, quintuplets, but anything more than 2, the risk of preterm labor is very high. So we do a fetal reduction process by putting intracardiac potassium chloride or lignocaine, or if the one baby is abnormal, the other baby is normal, then we can prevent other babies from growing by giving intracardiac KCL as one of the procedures. But then the most remarkable success rate in fetal therapeutic procedures is the conquest of RH disease. RH negative mother, RH positive baby, isoimmunization takes place. First baby somehow escapes, but second time they have severe RH isoimmunization. And subsequent pregnancies continuously. With every additional pregnancy, the severity increases, the onset becomes earlier. And the only treatment for that today, because by doing fetal middle cerebral artery Doppler, because way back in the 80s, I used to go and put a needle and aspirate the blood to go and check the hemoglobin. We had no other way of knowing whether it was anemic or no. But today, we do a fetal middle cerebral artery Doppler, and if the middle cerebral artery Doppler peak systolic velocity is double the gestational age, we know the baby is anemic. So quickly we give a intrauterine transfusion by giving O negative packed cells, and we did the first intrauterine transfusion in 1991, over 98% success rates, and we have completed close to 480 cases till now, and 97 to 98% success rate. Even with the baby's hemoglobin was only 1 gram in utero with severe high drops, these babies have survived. And we have followed these babies for more than 10 years or 15 years. They are doing very well. So RH is something which you'll never lose a baby because of RH. Never lose a baby because of RH, because that's a treatment which is possible. So every isoimmunized baby must be saved. Then we also have medical treatments. So here's a baby which has got a large goiter. Baby has got hypothyroidism. And it's hypothyroidism, we find out hypothyroidism at birth. But when there's a very large goiter, it can compress on the trachea, can cause polyhydramnios, and also can have respiratory problems at birth. So what we do is we do fetal intraamniotic thyroxine instillation. Every week we give 200 micrograms of thyroxine. Slowly you can see that thyroid shrinking. And when there is a supraventricular tachycardia, it can go into high drops. We can give the mother digoxin, we can give the mother flecainide, and immediately the cardioversion will happen, and they are fairly well sustained. And there are other things like fetal shunt procedures, endoscopic procedures, radiofrequency ablation, and fetoscopic cord occlusion. But we need to choose the right fetus, the right mother, the right time to do the procedure, and in the right hands. And we should always know when not to do anything. There is a problem, but we can say this problem does not require any intervention now. We'll wait for the baby to be born. So I'll take you an example of shunting. So here's a massive pleural effusion which is there, which is impending high drops. So what we are doing is we are putting a double pigtail shunt, and you can see the baby after birth, you can see the shunt there, which we remove. And this shunt helps to drain the fluid for about 3 to 4 weeks by the time the baby can be delivered. But the same success rate cannot be set for lower urinary tract obstruction. For this also shunting was very popular, but we know today that not something, we cannot guarantee long-term renal function even if you put the shunt. But also another method which we do is called fetal cystoscopy. We put a 1 millimeter cystoscope through the fetal bladder, and antegrade we go and fulgurate the posturethral valve using a laser. And that seems to be little better than the shunting process. Then congenital diaphragmatic hernia. Diaphragmatic hernia, you know, severe diaphragmatic hernias, you can have, oh, sorry. Anything happened? Okay, anyway, let me continue and give you the thing that will come, hopefully. So, diaphragmatic hernia is, we know, pediatric surgeons know that when there's a severe diaphragmatic hernia, chance of loss, neonatal loss is very high. Something is happening. Okay, so what they decided, very early, they used to open the abdomen, open the uterus, operate on the baby, get the diaphragmatic exercise and then do. But today, we have what is called as feto. This feto is, I'll show you this one here. We are putting a fetoscope through the baby's mouth into the baby's trachea, and we are putting a balloon. We put a balloon there, and the balloon is inflated at the level of the carina. So you can see the balloon there. It's completely inflated. So what happens is, this baby, the problem in diaphragmatic hernia was compression of the lung, and the lung liquid was getting out. So naturally the alveoli were not developing. So by closing the trachea, occluding the trachea, the fluid which was produced in the lung stayed in the lung, and the alveoli were expanding, and better chance of outcome was there. So these babies, so this is a procedure which has shown some degree of success. Then one of the next level of success, I should say, in managing complicated twins. So here, twin-twin transfusion syndrome, selective fetal growth restriction, abnormality in one of the monochorionic twins. We are not worried about dichorionic twins. It's only about monochorionic twins where the placenta, there is vascular anastomosis between one twin to the other. And when there is a twin-twin transfusion syndrome, we can put a fetoscope and we can dichorionize the placenta by doing a laser photocoagulation of the anastomotic vessels. And if there's an anomaly, I can do what is called as a bipolar cord coagulation. So here I'm using a bipolar forceps to go and catch the cord, and you can see fetoscopically the cord, with the white thing, the cord has been occluded there. And then we also have a condition called twin reversed arterial perfusion sequence, where we put a treatment called interstitial laser or intrafetal laser. An 18-gauge needle is put inside, and using a laser, we occlude the vessel which is going through the fetus. So complicated twins, we've done about 450 cases, and again the success rate about 60 to 70%, which is there. Now, chorioangiomas are completely outside the fetus, and they can cause havoc to the fetus. Large chorioangiomas can cause, they act like AV malformations, can cause cardiac failure in the baby, can cause severe anemia in the baby. So what we do is, we go and access the vessel which is supplying the chorioangioma, and we inject histacryl glue injection. Immediately within a few seconds, the vessels will get thrombosed and occluded, and the baby will come back to normal. So not all chorioangiomas require intervention. Out of the 65 cases we had, only 7 needed intervention. The others will do well on their own. Then comes the last frontier. The last frontier is fetal surgery for spina bifida. So fetal surgery took a resurgence again when they found there are many countries where termination of pregnancy is not allowed by law. Okay, and because of that, the mother comes at 26 weeks and they got a big spina bifida. So what they said, okay, anyhow you are not terminating the pregnancy, why not we try to repair the spina bifida in utero and see whether the outcomes are better. And surprisingly, that if you go and do an in utero repair of spina bifida, there were fewer number of babies with which required shunting, ventricular amniotic shunting after birth, and the motor mobility was much better in many of these babies. So very good success rates have been shown. And you can say this is an example of how the baby, they open, exteriorize the baby, then the neurosurgeon operates on the baby, and then they close it back, put back the amniotic fluid and do that. The only problem is the second, if you want to conceive a second time, then it becomes very difficult because they do a big classical incision on the uterus. So they said, let's move to fetoscopic surgery for spina bifida. And today, by using 4 ports, we can do a complete fetoscopic correction of the spina bifida for these babies. So the future, we talk about what's happening now, but let's talk about the future. In utero stem cell transplantation. We are almost there happening, okay? In utero stem cell transplant for single gene disorders. So I think they have approved now for hemophilia that because of the CRISPR, you can actually edit a gene. Okay, you can edit a gene and put it back inside, and we do the stem cell transplantation. The uptake, if it's good, then the baby is born without hemophilia. Okay, so that's a possibility. And then, so these are again, of course, done in very, very few centers in the world across now, and it will come for routine use very soon. Right. Then we are in the era of artificial intelligence. And so how are we going to use artificial intelligence in ultrasound? And I'm going to show you this machine which
depth increase.
So here you can see he's just talking to the machine, and the machine is doing what he's telling it to do. No buttons. He is not putting the keyboard. He say color mode, is switch on the color. Take off the color. So when you're doing an interventional procedure, you don't need somebody operating the machine. The person can actually do. So in intraoperatively you're doing in the theater, then you can give instruction to the machine will do it. This is one method of artificial intelligence. The other, of course, is when for example, I'm measuring the head of the baby. Routine measurements. I take multiple planes and all this happens, and the standard planes I go through. But when I put it through an AI program, so I just take a 3D sweep, right? And then see what happens now. So immediately it recognizes that I'm looking at the brain. The machine recognizes looking at the brain, and then it will take one sweep. I say update, it will take one sweep, and immediately within a second, all the planes are ready, and you say auto measure. It goes and measures all my measurements which I require, and I'll say, okay, auto comment. It will also go and say which are the parts. It labels the parts also. So the machine is able to do everything. And as I am scanning, it will capture whatever I want automatically. I said, get me the abdomen section, get me the foot section, get me the brain face, everything will capture automatically to do that. And this is very much in vogue at this point of time. So the time taken for a routine process is 2 minutes 22 seconds, and for this process it's only 52 seconds. So that's the time saving which you're going to get. So now I'll finally give you that concept of life of a baby from conception to delivery is a miniature version of life from birth to old age. I'll tell you why it is. So early pregnancy, 0 to 14 weeks. There is rapid growth in the prenatal period. And neonatal infancy is also rapid growth. So every time somebody comes and visits, oh, this baby has grown so much. Every time they see, even if they come after 2 weeks, they'll say, oh, baby has grown so much. Okay? So that's the rapid. The second trimester. Second trimester in the prenatal period, structure building, purposeful activity. When the baby moves its limbs, it's actually moving it very purposefully, opening and closing of hands, flexion, extension, because it's still gymnasium inside. It's developing its muscles because of that. And if it does not move, the muscles don't develop. So that's what happens in talipus, where when it's not moving, then that muscle becomes hypertrophic. So purposeful activity, major problems manifest. So naturally, this is early childhood and adolescence where maximum problems exist in the human being at that point of time. Right? Then you go to early third trimester. The growth slows, there's lung maturity is happening. So the baby comes to a deliverable age where lung maturity is there. It's like middle age, where we are supposed to have mental maturity and stability in our lives during the middle age which we are there. And then when you go to the late third trimester, there's minimal growth, the movements are slowing down, and at old age, we are supposed to be reduced activity and slow and steady. And like me and Dr. John Vasigaran here, we are not armchair people. But then that's the norm. Okay, you definitely slow down over a period of time. And so what we are looking ex utero life and in utero life is just a miniature form. So why I'm saying this is because you need to treat that in utero life as you will treat an ex utero life. You can't take it for granted. You have to do what it is required. You have to ensure the environment is safe. You have to ensure the baby gets the best of things. It is interacting with your environment all the time. So preserve it and celebrate it as much as possible. So the journey of understanding of a life goes on, right? So the end of the journey, happy babies and happy parents. That's all we are looking at, isn't it? So this is the baby with the intrauterine transfusion which was given for RH disease, a twin pregnancy, and both babies are very happy and the parents are very happy. So Dr. A.L. Mudaliar said, pregnant obstetric management is watchful expectancy with masterly inactivity. You can see in A.L. Mudaliar's book, it's written there, right? It's a forward line. It's there, okay? But today, this has changed, right? It is high expectations and judicious activity. Because that's what has changed. Do that. The way we look and manage pregnancy has changed. The pregnancy has not changed, but the way we look and manage. So I always tell my patients, pregnancy came before doctors came. Okay, we are very worried about it, pregnant doctor. We are only trying to find out. I am not doing a scan to find out whether something is abnormal. I am trying to find out doing a scan to tell you everything is normal. Because 97% of pregnancy will still be normal. That's the kind of reassurance that we need to give, right? So lastly, I would like to show you, this is what we have developed in IIT. It's a robotic ultrasound, okay? So here's a pregnant lady, you can see the robo moving there, and it is capturing all the images automatically, and it will also give you a report. Just press one button, it will give you a report. This is work in progress, but very soon you will see robotic ultrasound is actually a reality. Thank you very much for this patient opportunity.
Thank you so much, sir, for sharing your expertise with us today with this incredibly insightful and thought-provoking presentation.
Friends, you all would agree with me that we all had a wonderful feast, scientific feast, and being it is an oration, there should not be any questions. Let us give you a big hand for the wonderful lectures given by our Professor Suresh. And he has mentioned in his last slide, there is watchful expectancy and masterly inactivity. And Suresh has also given some definition. A.L. Mudaliar is the one who inaugurated our college in the year 1960. And today we all had a wonderful time, Suresh, for your excellent oration. And we are all, blessed, and we are all proud of you, Suresh.
Thank you, sir. We now invite Dr. Pichumani, sir, Treasurer of the Chemco Alumni Trust, to deliver the vote of thanks.
Good afternoon to all of you. I think we are coming to the end of this fantastic program. And really, sir, and no words to talk about this. And we should really thank Dr. Panneerselvam, sir, Dr. Ilanguvan, sir, for having arranged the Endowment Oration was actually started by both of them. And this is supposed to be held this year in MGR University because of the pressure from the Vice Chancellor. And somehow we just cancelled it. We got it only in our college. And all the juniors would have really got it very nicely. And so we should congratulate this. And I thank our Dean who has given permission for us to conduct this fantastic program, sir, Dr. Professor Shivashankar, sir. I thank our MS Jyotikumar, sir. I thank AP. I thank Professor Suresh, sir, for having a very fantastic given lecture, Life Before Birth, a beautiful journey, and coming with a new saying, sir. And it's going to be in the modern textbook of obstetrics. We are going to find it everywhere, sir. And of course, I thank thank our teacher, Professor John Vasiran, sir, who has taught us to just say, he was the one to say, before you examine the patient, examines you. So I really would remember that whenever we see patients, remember that before we examine the patient, examines us. Thank you, sir, for coming and gracing the occasion, sir. I thank all the professors, head of the departments of Chengalpattu Medical College, who has been very gracious enough to be present here, actually, and also send the students. I thank all our alumni who have been juniors and senior, juniors here who are sitting in front of me. I thank Dr. Anand, sir, who was very instrumental in bringing out this trust. I thank Dr. Shekhar, sir, Professor Shekhar, sir, and everyone. I think I have not left any, and I really thank all our junior guys who have done a good job in coming out of the beautiful way. I thank our organizers here, and of course all the people who have been interested, who have done a good job. I thank Ram Kumar, who has been instrumental in bringing out this, and has been working with us for the past 15 days for this particular program, sir. I thank everyone, and I just invite you for lunch. Thank you.
Thank you, sir. We request everyone to rise for the national anthem.
भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उत्कल जलति तरंगा तव शुभ नामे जाहे तव शुभ आशीष माहे काहे धवसय गाधा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you everyone. Please join us for lunch.